Hi everyone, I'm Dr. Ainul Basira from Department of Ophthalmology, University Science Malaysia. I present on a rare case of orbital melioidosis due to gardening. So, melioidosis, melioidosis is an infection caused by a gram-negative bacilli, Buccoderia pseudomale. It is endemic in the certain part of world involving Southeast Asia and Northern Australia. So it is a multi-system disease and can vary from benign skin and soft tissue infection to a rapidly fulminant septicemia. And it occurs predominantly in those with underlying comorbidities as it is recognized as opportunistic pathogen. And ocular involvement of melioidosis is very rare. So my patient is a 54 years old Malay lady with underlying diabetes mellitus and hypertension. She presented with left progressive upper lid swelling and fever for 1 week. Otherwise, vision was not impaired and she denied diplopia. She denied history of traveling, jungle trekking, but she did some gardening at home every day. Examination revealed a non-septic looking lady. There was left non-axial proptosis, meaning the proptosis is non-central with periorbital fullness and redness, as we can see at the first picture. There was a significant limitation of the left eye elevation. However, there was no diplopia, as we can see at the second picture. The rest of ocular examination were unremarkable. Cardiovascular, respiratory, and abdomen examination were normal. Her random capillary blood glucose in ward were uncontrolled, ranging from 9 to 16 millimole per liter. Her inflammatory blood marker were markedly elevated. Her blood culture grew Buccoderia pseudomale, which was sensitive to ceftazidime, bactrim, imipenem, and meropenem. An urgent CT scan of brain and orbit performed showed collection at left superolateral extracorneal region. She was treated with IV ceftazidime, 2 gram TDS, then oral bactrim was added after 4 days in view of persistent fever. Then IV ceftazidime changed to IV meropenem after consultation with infectious disease physician due to persistent fever and to cover for possibility of a CNS extension. Ultrasound abdomen was normal. In view of persistent unresolved fever and orbital sign despite antibiotic, we performed left lateral orbitotomy via lateral canthotomy and drainage of the abscess under general anesthesia. The abscess drained and the filament was sent for culture and sensitivity, which similarly grew Buccoderia pseudomale. Post drainage, the temperature settled down and diplopia improved and the extraocular muscle movement was markedly improved. There was a bilateral multifocal choroiditis later in the course. However, it does not show any extension of the septic foci to the vitreous cavity, and it maintained for 3 months. And she is well and shows no sign or symptom on follow-up upon completion of antibiotics. So Buccoderia pseudomale has natural reservoir in the soil and water, which can be spread through inhalation or direct contact. So in this patient, she is most probably obtained the bacterial infection from her hobby gardening. Ocular manifestation, as reported by Yai Sawang, based on his 23 years retrospective review of ocular melioidosis. However, he revealed that ocular involvement of melioidosis can be devastating, as 68% of the patient ended up blind. And melioidosis manifests as orbital abscess, like my case, is very rare, and only one case reported in Malaysia in 2008. Although ocular manifestation of melioidosis is considered rare, but there's possibility that they were underdiagnosed, as patients usually treated for life-threatening symptom and may be missed to be referred to ophthalmologists. So my conclusion is a multidisciplinary approach is required, as it can cause significant morbidity and mortality. With that, I thank you.